Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces. I'm Jude Abdalla, your host for today's episode, and I'm joined by the amazing Serina Abushaikha.
Hey Jude, I'm very excited to dive into today's topic. It's going to be all about anti-diabetic drugs, be it oral or injectable. I don't want to spoil much, but we'll walk through their mechanisms, classifications, the different classes, and their side effects.
That's a pretty long list. Is there anything else?
Not to forget, we will also look into when and where we use certain drugs.
Sounds like we need to buckle up. Before we get deep into the drugs, could we get a quick background to recall what diabetes actually is?
Of course, in short, diabetes mellitus is a condition where the body struggles with blood glucose control. There are two types, type 1 and 2. When beta cells are destroyed and there is no insulin production, this is called type 1. The patient becomes insulin dependent, usually before age 30. Type 2 happens later on, typically after the age of 40, and involves either not enough insulin production or cells not responding well to insulin.
If I remember correctly, even type 2 patients can end up insulin dependent eventually.
You're right.
Alright, that gives us a good foundation for this conversation. Now, onto how these medications actually work. What is the general approach to controlling blood sugar?
That's a great question. We can think of blood sugar control like managing city traffic. You can block new traffic from entering, make cars move faster through roads, build detours, or even get rid of some cars altogether.
So, in terms of medicine?
The medication can decrease hepatic glucose output, increase glucose uptake into cells, increase insulin secretion, delay glucose absorption, and increase urinary glucose excretion.
Perfect. Let's start by discussing the most common form of drugs, oral tablets. Could you tell us how these antidiabetics are classified?
Brace yourselves, there is a list incoming. They fall into several categories based on their mechanisms. We have insulin secretagogues like sulfonylureas, meglitinides, insulin sensitizers, biguanides like metformin and thiazolidinediones, modifiers of glucose absorption like acarbose, DPP-4 inhibitors, GLP-1 agonists, and SGLT2 inhibitors.
Alright, we definitely need to take this step by step. Serena, let's start with the insulin secretagogues, particularly the sulfonylureas. What is the class of this drug?
Sulfonylureas are classic insulin secretagogues. They help the pancreas squeeze out more insulin by binding to SUR. It is a specific receptor located on the ATP-sensitive potassium channels in beta cells. The group is further divided into first-generation drugs like acetohexamide and tolbutamide, and second-generation drugs like glyburide, glimepiride, and gliclazide.
Interesting. So, they give the pancreas a little push to secrete insulin through their action on potassium channels?
Exactly. Let me elaborate on their mode of action a little more. When sulfonylureas bind to the SUR on the KATP channels, they cause the channels to close. This depolarizes the beta cell membrane, opens calcium channels, lets calcium rush in, and trigger the release of insulin.
Okay, but there must be a catch. What are their side effects?
Here are some important ones to keep in mind. A major concern is hypoglycemia, especially if meals are skipped or dosing isn't adjusted properly. Insulin promotes fat storage, so weight gain can be another issue with this drug. There is also a risk of hyponatremia, and in rare occasions, you would find allergic reactions on the skin.
Does this apply to both generations of this drug?
Actually, first-generation sulfonylureas carry a higher risk of side effects compared to second-generation ones.
Okay, and can we notice these signs easily?
You're asking all the right questions, Jude. If a patient is also on non-selective beta blocker, the classic warning sign of hypoglycemia, like fast heartbeat, can be masked, making hypoglycemia harder to recognize and treat.
Wow. So you have to be really careful with the combinations. How would I know what patients to use them with?
We use sulfonylureas mainly for early stage type 2 diabetes, especially if we're concerned about the cost. However, they are contraindicated during pregnancy. We also have to be very cautious in patients with kidney and liver impairment because it would increase the risk of drug accumulating and prolonging the hypoglycemia.
Hmm. So, if I were to choose one drug, which one should I opt for?
Second generation drugs like glimepiride are preferred now. They're stronger, safer, and better tolerated.
That was quite a ride. I understand sulfonylureas really well after that breakdown. Can you tell us about meglitinides?
Meglitinides are also insulin secretagogues, but unlike sulfonylureas, they act faster and last for a shorter duration. This class of drugs include ripaglinide and nateglinide.
Okay, so the way I understand this is that they're like a quick push from the cells instead of a long squeeze.
Exactly, great way to think of it. And just like sulfonylureas, they also close the potassium ATP channels on beta cells to trigger insulin release. The difference is that they bind to a slightly different site. Their rapid onset and short duration makes them perfect for handling those post-meal glucose spikes.
And what about their side effects? Do they differ from sulfonylureas?
They are similar in some aspects. The main concern is still hypoglycemia, which commonly occurs if the patient takes a dose and then skips a meal. Weight gain can also occur, although it's typically milder than with sulfonylureas. The difference is that patients might report respiratory tract infections or joint pain, but it is rare.
While side effects are definitely something to look out for, we need to choose the right patient too. What is the case with these drugs?
You're right. When it comes to meglitinides, they are a good option for type 2 diabetic patients with irregular eating patterns because you can adjust the dose timing around meals. But we avoid them in patients with severe liver disease and use with caution on those with kidney issues.
Patients aside, are there any drugs that we must avoid when prescribing meglitinides?
Ripaglinide is metabolized by CYP3A4. So, when this enzyme is inhibited by drugs like erythromycin, fluconazole, levels of ripaglinide can increase dangerously. Conversely, inducers like rifampin can decrease its effectiveness.
Got it. So do not give it to patients who are using erythromycin, fluconazole, and rifampin.
I almost forgot gemfibrozil. This is a lipid-lowering drug which also should not be used together as it can dramatically heighten the effects of ripaglinide, risking severe hypoglycemia.
That was super clear. I'm starting to enjoy this. Would you like to pick our next drug of discussion?
Let's do biguanides, starting with the famous metformin.
Metformin it is. All right, Serena, give us the full breakdown.
Metformin is really the star of the biguanides class. It's considered an insulin sensitizer, so it increases the body's response instead of directly stimulating insulin secretion, which is a big reason why it does not cause hypoglycemia.
How does it actually work?
Metformin mainly decreases the hepatic glucose output by inhibiting gluconeogenesis in the liver, but it also improves insulin sensitivity in peripheral tissues like muscle cells, helping them absorb glucose better.
All right, let's discuss.
Not yet. This drug also slows down intestinal glucose absorption and increases anaerobic glycolysis, which increases lactic acid mildly. So, it's tackling glucose from multiple angles.
Wow, so far this drug sounds like a powerhouse, but I think there might be a catch to it.
You got me. Metformin is generally well tolerated, but we commonly see GI side effects early on. They can manifest as diarrhea, bloating, abdominal cramping, and nausea, which can be bothersome. Long-term use can lead to vitamin B12 deficiency, but this is rare. Another rare but very serious complication is lactic acidosis. Patients with renal impairment, alcoholism, or old age are at a higher risk for it.
In short, GI effects are usually seen along with rare instances of vitamin B12 deficiency or lactic acidosis. So when do we use metformin and when should we avoid it?
Actually, it is the first-line therapy for type 2 diabetes unless contraindicated. Interestingly, it's also useful in patients with polycystic ovary syndrome, PCOS, because insulin resistance plays a big role in its pathophysiology.
I see. And who wouldn't receive it as a first-line treatment?
Those include patients with significant renal insufficiency, liver failure, alcoholism, or any hypoxic state. Basically, anything that could increase the risk of lactic acidosis.
Metformin seems to offer a lot of benefits. Are there any other points we should know of?
Definitely. It can also cause modest weight loss. Patients often lose a bit of weight because it decreases the appetite. And a major plus, metformin does not cause hypoglycemia when used alone.
Wow, I can see why it's so widely used. Fun fact, it also has a strong safety record over decades and even shows benefits in reducing macrovascular complications like heart attacks.
Absolutely.
All right, Serena, let's talk about the next group of insulin sensitizers, the thiazolidinediones.
Sure, let's dive in. Thiazolidinediones are another class of insulin sensitizers. They are often called TZDs. Instead of pushing the pancreas to increase insulin, they make the body more responsive to the insulin it already has. The main drugs here are pioglitazone and rosiglitazone.
So they work behind the scenes to boost sensitivity?
That's a great way to put it. They work in a unique way compared to other classes.
I'm all ears.
TZDs activate a nuclear receptor called PPAR-γ or peroxisome proliferator activated receptor gamma. It is found in adipose tissue, cardiac muscle, skeletal muscle, and the liver. When activated, it influences gene transcription related to glucose and fatty acid metabolism. This leads to improved insulin sensitivity, better glucose uptake in muscles and fat, and reduced hepatic glucose output.
Wow. Aren't they literally changing how the body manages sugar at the genetic level?
Yes, exactly. Think of it like rewiring your body's metabolism.
Okay, but wouldn't such a fascinating mechanism come with its own baggage of side effects?
Absolutely. First, they cause fluid retention, which can lead to peripheral edema. That's why we have to be very cautious in patients with heart failure. They also cause weight gain, and this can frustrate patients trying to manage their diabetes. We also see osteopenia and fractures, particularly of the upper limbs. It is more common in women.
Are there any differences between the two drugs we named in this class?
Rosiglitazone has been linked to an increased risk of cardiovascular events, while pioglitazone has been associated with increased risk of bladder cancer with long-term use.
That sounds like a lot of risks to balance.
Exactly. Even though TZDs can be very effective, they're definitely not for every patient. Patients with type 2 diabetes who have significant insulin resistance benefit from TZDs. They're often used in combination therapy. However, they are contraindicated in patients with NYHA class 3 or 4 heart failure. Also, we need to be cautious if there is a history of bladder cancer or osteoporosis.
NYHA class 3 or 4?
It stands for New York Healthy Association. Class 3 or 4 refers to advanced stage of heart failure according to the NYHA functional classification. These patients are at a risk of fluid overload due to these drugs.
So it's all about picking the right patient and monitoring them closely.
Yes, it's kind of like a balance between potential benefits and very real side effects. Though they sounded overwhelming, there are some benefits to take note of. TZDs don't cause hypoglycemia when used alone, and they can be used in patients with renal insufficiency. This can be a big advantage when metformin isn't an option.
Okay, let's move on. I would like to get to know the modifiers of glucose absorption. What are they?
Nice choice! These are alpha glucosidase inhibitors. Acarbose and Miglitol are the main ones to keep in mind. They don't directly affect insulin at all. Instead, they work inside the gut.
Interesting. So they're interfering before glucose even enters the bloodstream?
Exactly. They act like speed bumps for carbohydrate digestion by inhibiting alpha glucosidase enzymes, which are located in the brush border of the small intestine. Normally, they help break down complex carbohydrates into simple sugars for absorption. So, when acarbose and Miglitol block them, they delay glucose absorption and dampen the postprandial rise in blood glucose.
Is it slowing down what we call a sugar rush?
Yup, exactly. You still digest carbs, but it's much slower, and since they aren't fully digested, they travel further down the intestine, where gut bacteria ferments them. That leads to a lot of GI side effects. Flatulence, diarrhea, and abdominal cramping are really common. It's sometimes called the bloat blocker effect.
That's definitely memorable. So, GI side effects are expected pretty much always?
Very expected, especially when first starting therapy. That's why patients need to increase their dosage gradually. While we're on this topic, indications of this drug are type 2 diabetics who have significant postprandial glucose spikes.
That makes sense. And since the gut is already sensitive, they would be contraindicated in patients with inflammatory bowel disease, colonic ulceration, or any serious intestinal obstruction or digestion disorders, because delaying carb digestion could worsen these conditions.
You're right. You catch on quick, Jude. Plus, compared to other classes, they're not super potent at lowering HbA1c, so they're often used as adjunct therapy. You should note that if a patient taking alpha glucosidase inhibitor develops hypoglycemia because they're on insulin too, it must be treated with pure glucose, for example, glucose tablets, and not sucrose. This is because sucrose digestion is blocked by these drugs.
Awesome. So slow the sugar, but watch the gut. That was an interesting drug. Next up, how about incretin-based therapies? Let's start with the DPP-4 inhibitors.
DPP-4 inhibitors include drugs like sitagliptin, linagliptin, and vildagliptin, which is why they are also called gliptins. They're a newer oral class and work by enhancing the body's own incretin system.
Got it. So when we hear the word gliptins, immediately think of DPP-4 inhibitors. And incretins, those are the gut hormones, right? Like GLP-1?
Yes, when we eat, our gut releases incretin hormones like GLP-1 and GIP, which increase the insulin secretion and decrease glucagon. Normally, DPP-4 breaks them down. So, when DPP-4 gets inhibited, the action of these helpful hormones gets prolonged. These drugs also aid without straining the pancreas too hard.
So they're kind of like a natural booster for the body's insulin response?
Exactly. They are helpful to the body itself, especially after meals. They're actually pretty well tolerated.
But they definitely have some side effects, don't they?
Of course, side effects can include nasopharyngitis, think mild sore throat or cold symptoms, headache, and occasionally hypersensitivity skin reactions. Pancreatitis is a rare but serious side effect.
Got it. I'm kind of curious about it since we haven't heard of it yet, but is there any risk of cancer?
There's actually some theoretical concern about intestinal cancers, but it's not conclusively proven yet. It's still under study.
So who are these drugs usually meant for? Could you also tell us who would be recommended against it?
Gladly. DPP-4 inhibitors are great add-ons for type 2 diabetes, especially when metformin alone isn't enough. They're particularly useful because they don't cause weight gain and have a low risk of hypoglycemia when used alone. However, caution is needed in patients with a history of pancreatitis.
No renal issues?
Actually, some DPP-4 inhibitors need renal dose adjustment, like sitagliptin, while others, like linagliptin, don't.
I love how they work so gently but effectively. What about GLP-1 receptor agonists? I heard they're getting pretty popular.
Yes, let's jump into that next.
All right, Serena, we're ready. I hear these are really exciting in diabetes treatment.
Exciting is definitely the way to go. GLP-1 receptor agonists are actually a class of injectable drugs that mimic the action of natural incretin hormone GLP-1 or glucagon-like peptide 1. The main drugs in this group include exenatide, liraglutide, dulaglutide, semaglutide, and more recently, the dual agonist, tirzepatide.
I see a lot of tides, and I'm guessing all of them boost the body's own insulin?
Yes, but in a really smart way. They increase insulin secretion, but only when glucose levels are elevated, so you get glucose-dependent insulin release. This reduces the risk of hypoglycemia. Not only that, GLP-1 also decreases glucagon secretion, slows gastric emptying, and reduces appetite, so they hit multiple points.
Wow, a full body metabolic reset. They help the pancreas, regulate liver glucose output, delay the stomach from emptying too fast, and even signal the brain to curb hunger.
Absolutely. And slowing gastric emptying also helps prevent big blood sugar spikes after meals. When it comes to side effects, they usually lessen over time as the body adjusts. The most common ones are gastrointestinal, nausea, vomiting, constipation, diarrhea, and loss of appetite. A more serious but rare complication is pancreatitis, inflammation of the pancreas. It's something we always warn patients about.
I see. Is there any concern with weight gain?
It's actually the opposite. GLP-1 receptor agonists are famous for weight loss, which is a major plus for many type 2 diabetics struggling with obesity. It's partly due to delayed gastric emptying and appetite suppression.
Is this more for type 2 diabetics again?
They are indeed, especially in overweight or obese patients. They're also great when we want an agent that lowers both blood sugar and body weight. However, they should not be used in patients with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2, MEN2, because there is a potential risk of thyroid C cell tumors.
That's a really important safety tip. Anything else we should note?
Yes, they are all administered subcutaneously, but their timings differ. Liraglutide is once daily, exenatide is given twice daily, dulaglutide and semaglutide can be dosed once weekly. Tirzepatide, the dual GIP and GLP-1 agonist, is also once weekly and shows even better glucose control and weight loss compared to selective GLP-1 agonists.
Tirzepatide sounds like a game changer.
It really is. Plus, tirzepatide recently got an FDA approval for not only diabetes and obesity, but even for moderate to severe obstructive sleep apnea in obese adults.
All right, Serena. We teased it earlier. Let's talk about the SGLT2 inhibitors now. What are these all about?
SGLT2 stands for sodium glucose cotransporter 2 inhibitors. These inhibitors are a newer class that works at the level of the kidney instead of pancreas or liver. Major examples include canagliflozin, dapagliflozin, and empagliflozin.
Oh, these are the pee the sugar out drugs?
That's the perfect way to remember them. You will find SGLT2 transporters located in the proximal tubules of the kidney, responsible for reabsorbing about 90% of the filtered glucose. These drugs inhibit the SGLT2 and prevent glucose reabsorption, causing increased urinary glucose excretion. This results in lowered blood glucose levels.
Simple, but super clever. Just get rid of the extra sugar. But wouldn't interfering with transporters have an effect on the electrolytes?
Yes, they also cause some sodium loss, which leads to mild osmotic diuresis. So patients can even experience hypotension due to volume depletion. There are few other important adverse effects too. The most common one is female genital mycotic infections, basically yeast infections, and urinary tract infections because of extra sugar in urine creating a breeding ground for bacteria and fungi.
And what about the rare ones?
Rare but serious complications include euglycemic diabetic ketoacidosis and necrotizing fasciitis of the perineum, known as Fournier's gangrene.
Whoa, that definitely sounds really bad. But they don't happen often, right?
Yes, they're very rare, but it's important to remember and counsel patients about hygiene and hydration. SGLT2 inhibitors are preferred for, take a guess, type 2 diabetes, especially in patients who would benefit from additional weight loss and blood pressure reduction. There is also strong data suggesting cardiovascular and renal protection, so they're often preferred in diabetics with heart failure or chronic kidney disease.
So they actually protect the heart and kidneys too. And since they work on the kidneys, we do not give them to patients with severe renal impairment and patients at risk of frequent urinary infections.
Yes, huge bonus! Many guidelines now recommend SGLT2 inhibitors early if a diabetic patient has heart failure, chronic kidney disease, or even just multiple cardiovascular risk factors. Small mental note though, they cause glucosuria, so patients will have positive urine glucose test, but this is completely normal. Also, we should advise the patient to stay well hydrated to prevent hypotension, especially elderly individuals.
All right, Serena, I really want to jump into injectable therapies, but let's quickly touch on combination treatments first. I always see patients on combo pills. What's the idea behind combining drugs?
Good observation, Jude. In type 2 diabetes, as the disease progresses, sometimes single drug therapy isn't enough to control the blood sugar. Combination therapy lets us attack the problem from multiple angles, like decreasing hepatic glucose output, improving insulin sensitivity, boosting insulin secretion, and even blocking glucose absorption, all at once.
That feels like a teamwork approach happening inside the body.
Think of it as recruiting a full squad instead of sending just one player into the field.
Let's get into some specific examples, shall we? First up, we've got glyburide and metformin.
Sure, glyburide is a sulfonylurea that enhances insulin secretion from the pancreas. Metformin works by decreasing insulin resistance, increasing peripheral glucose uptake, reducing hepatic glucose production, and decreasing intestinal glucose absorption.
So when you combine them, you get a powerful synergy, more insulin from the pancreas and better use of that insulin, leading to improved glycemic control. That makes a lot of sense.
Totally. But we have to be careful. Combining sulfonylurea with metformin increases the risk of hypoglycemia, especially if meals are skipped or dosing isn't properly adjusted.
Yes, that list of effects was pretty long. And what about vildagliptin plus metformin?
Remember gliptin? Vildagliptin is a DPP-4 inhibitor, so it enhances endogenous insulin secretion and decreases glucagon levels after meals. When paired with metformin, which, as we said, improves insulin sensitivity and reduces hepatic glucose production, it results in a very effective reduction in both fasting and postprandial glucose levels.
So here, we're combining boosting incretin hormones with reducing liver glucose production.
Yup, that's it. It's a smooth, complementary mechanism without causing a lot of hypoglycemia or weight gain. And this combination tends to be better tolerated than sulfonylurea combinations, especially for patients who struggle with hypoglycemia risks.
I love how logical this layering is. Pick two mechanisms that don't clash but instead strengthen each other.
Exactly. That's the philosophy behind combination therapy in diabetes. Pick agents that complement each other and hit different parts of glucose regulation pathway.
Alright, Serina, I think it's time. After covering the oral agents, it's time to move on to the injectables. What is the big picture overview here?
Injectable therapies mainly include insulin preparations, but we also have some non-insulin injectables like pramlintide and GLP-1 receptor agonists, which we already touched on.
I have a question. Before we get into all the types of insulin therapies, could you briefly tell us why we even need insulin injections in diabetes management, especially when there are already so many oral medications?
Great question, Jude. The core reason is that diabetes, especially type 1 and advanced type 2, involves a deficiency of insulin. Either the pancreas isn't making enough, or the body's resistance becomes so strong that oral agents alone can't overcome it anymore. Insulin injections are essential to directly replace or supplement the missing hormone.
So it's like the body physically cannot produce anymore and thus we're supplying it?
You got it. In type 1 diabetes, the beta cells are destroyed, so patients have absolute insulin deficiency from the very beginning. They could quickly develop dangerous conditions like diabetic ketoacidosis and even die without insulin.
Noted. Insulin is literally life-saving in type 1.
And even in type 2 diabetes, many patients experience progressive beta cell failure over time. The oral meds start becoming less effective because there is just not enough insulin being produced naturally. So, injections are needed to maintain blood sugar control.
When is insulin especially considered in type 2 diabetics?
There are several important scenarios where we think about starting insulin in type 2 patients. 1. History of ketoacidosis. Even if they're type 2 diabetic, if they have diabetic ketoacidosis, they need insulin. 2. Severe hyperglycemia. When the symptomatic blood glucose is more than 300 mg per deciliter. 3. Acute serious illness or surgery, because stress hormones spike and cause massive insulin resistance. 4. Pregnancy. The oral agents have limited safety data. Therefore, insulin is preferred. 5. Failure of oral therapies, defined as 2 to 3 oral agents failing to meet glycemic targets after 3 to 6 months. 6. Weight loss with hyperglycemia. It is a sign of severe insulin deficiency. And finally, use of high-dose steroids, which can cause extreme insulin resistance.
Wow. So insulin isn't just for type 1. It's crucial even in advanced type 2 and acute illness. And just so I know I got it right, insulin is preferred in cases of DKA history, severe hyperglycemia, acute illness or surgery, pregnancy, oral therapy failure, weight loss with hyperglycemia, or high doses of steroids.
Exactly. It's all about matching the therapy to the body's needs. If the body can't produce enough insulin, or if resistance is through the roof, injecting insulin directly is the most reliable way to protect the patient.
That's a great point. I always hear terms like rapid acting and basal insulin. Can you walk us through those?
Sure thing. Insulin preparations are classified based on how quickly they start working, which is the onset, when they hit their peak effect, and how long they last, which is their duration. Here is the broad classification into 4 groups. Rapid-acting insulin, like insulin lispro, aspart, and glulicine. Short-acting insulin, mainly regular insulin. Intermediate-acting insulin, like NPH and Lente. And long-acting insulin, like glargine, detamir, and degludec.
Okay, so it's all about how fast and how long they work.
Exactly. And this lets us adjust the insulin therapy to mimic natural pattern of insulin secretion, both the constant basal background level and the sharp bolus spikes after meal.
Let's break them down one by one, starting off with rapid acting.
Lispro, aspart, and glulicine are rapid-acting insulin. They start to have effects within 15 minutes after injection subcutaneously. Then they peak at about 1 to 2 hours and last up to 3 to 5 hours. They're specifically made to control postprandial glucose spikes, meaning blood sugar that rises after eating.
Kind of like giving backup insulin right when the food sugar shows up. So patients would have to take it right before their meals, right?
Exactly, either before eating or sometimes immediately after if needed. Another important fact about them is that these are the type of insulin that can be given intravenously in emergencies like diabetic ketoacidosis.
Now, on to regular insulin, which is a short acting insulin. What's different here?
Regular insulin is a little slower. Its onset is about 30 minutes to 1 hour after injection. Its levels peak at around 2 to 4 hours and they stay for about 6 to 8 hours. Because there is a delay in the onset, patients are usually advised to inject it 30 minutes before having a meal. Just like rapid-acting insulins, it can also be used intravenously, especially in inpatient settings.
Great. The next one would be the intermediate acting insulins, like NPH.
Neutral protamine hagidorn or NPH and lente insulin kick in around 2 to 4 hours, spike up around 4 to 12 hours, and can last up to 18 hours. They're primarily used to provide basal insulin coverage. This would be to control the blood sugar between meals and overnight.
But they have that peak, right? So would there be hypoglycemia risk?
Correct. Because they have a clear peak, patients need to be really careful with meal timing to avoid late hypoglycemia.
And finally, we've reached long-acting insulins, glargine and detamir.
They kind of sound like potions. Anyways, long-acting insulins have almost no peak. They provide a steady background insulin level. Glargine starts working in 1 to 2 hours and lasts about 20 to 24 hours. Detamir is similar, but may need twice daily dosing in some cases. Degludec has the longest action, lasting over 42 hours, allowing very flexible dosing.
So degludec works for a pretty long time, almost as if it's stuck like glue. Get it?
Jude, I guess that's one way of remembering it.
They sound perfect for maintaining stability without unpredictable effects.
Exactly. They are often referred to as basal insulins because they suppress glucose production between meals and overnight. They basically act like constant low-level insulin secretion from the pancreas.
Alright, Serina. Now that we know why insulin injections are needed, hearing the word basal reminds me of something I recently heard. Basal bolus therapy. Can you explain how we actually structure the insulin therapy?
Sure thing. Basal bolus insulin therapy is considered the gold standard for mimicking the body's natural insulin secretion. It's basically trying to copy what a healthy pancreas does.
Sounds logical so far, but how does it work?
The pancreas normally releases insulin in 2 patterns. Basal secretion, which is a slow, steady trickle of insulin throughout the day and night to keep glucose levels stable between meals and overnight, and bolus secretions, which is sharp bursts of insulin after eating to handle the rise in blood sugar from meals.
So basal covers the background needs and bolus covers the meals?
Exactly. Can you think of which drugs we would be combining to achieve these effects?
Rapid acting and long acting?
Point to Jude. In basal bolus therapy, we combine a long-acting insulin like glargine or detamir to provide basal coverage with a rapid-acting insulin like lispro or aspart, which is given before meals to provide bolus spikes.
That's so clever. It really does sound like we're trying to replicate the natural rhythm.
Exactly. And the beauty is that it allows greater flexibility in timing and quantity of meals and better overall glucose control.
This form of insulin therapy already sounds amazing, but can you tell us some more benefits?
Some major plus points of using basal bolus regimen would be increase in physiological insulin delivery, mimicking normal patterns. 2. A better HbA1c control compared to simpler regimens. 3. It offers flexibility with meals and snacks. And finally, it lowers risk of long-term microvascular complications like nephropathy and retinopathy.
Sounds like a win, but I feel like injections can be harder for patients to manage.
True, it can be a little more complicated because it involves multiple daily injections, MDI, typically 1 to 2 basal injections and 3 bolus injections every day. They also need to monitor their blood glucose closely and adjust doses around meals and activities.
Okay, so in short, it's the best at mimicking normal physiology, but needs more patient engagement and attention.
Exactly. But when patients are motivated, it provides incredible control and improvements in quality of life.
Alright, I have to admit, basal bolus therapy sounds great for mimicking natural insulin patterns, but I've also seen another way. Insulin pumps. How do those work?
An insulin pump provides continuous subcutaneous insulin infusion, often called CSII. It's like high-tech version of basal bolus concept.
So instead of multiple injections, the pump is doing it automatically?
Yup, the pump is a battery-operated device about the size of a pager. It holds a tank filled with rapid-acting insulin. This would usually be Lispro, Aspart, or Glulicine. Then, this insulin is delivered into the body through a catheter, which has been inserted under the skin and kept in place for about 2 to 3 days.
So it's like our own little pancreas. We've covered how insulin is delivered, whether by injection or by pump, but what do these patients need to watch out for?
There are definitely some important things that both patients and doctors need to keep an eye on. Hypoglycemia, lipodystrophy, and weight gain are the big three.
Hypoglycemia sounds like the most serious one. Let's start with that.
Absolutely. It's the most common and most dangerous side effect of insulin therapy. It usually happens when too much insulin is given compared to the amount of food they're having or their activity levels.
So that would be if a patient injects their usual insulin dose but skips a meal?
Exactly, or if they exercise more than usual without adjusting their insulin. The warning signs of hypoglycemia include tachycardia, meaning a fast heartbeat, along with sweating, tremors, feeling of anxiety, and intense hunger. If it becomes even more severe, patients can experience confusion and even loss of consciousness.
That sounds scary. That's why recognizing the early signs is so critical. Catching it early can prevent dangerous outcomes.
No doubt. That's why educating the patient about recognizing early symptoms and carrying fast-acting glucose sources like glucose tablets or juices is critical.
Okay, and what's lipodystrophy?
Lipodystrophy refers to abnormal fat distribution, which happens at insulin injection sites. It can manifest as either lipoatrophy or lipohypertrophy. From their names, you can make out that lipoatrophy would be loss of fat tissue in that area, creating small dents under the skin. On the other hand, lipohypertrophy is the buildup of fat tissue, which would cause lumps or thickened areas.
Does this happen to everyone since it's at the site of injection?
No, actually, it mostly happens when patients inject into the same spot over and over. Rotating injection sites using a different area each time is the key to prevent this.
And if you inject into a lipohypertrophied area, is insulin absorption affected?
Exactly, which can mess up glucose control badly.
Alright, last but definitely not least, weight gain.
Yes, insulin promotes anabolism, which means that it helps the body store glucose, fat, and protein. So, when we start insulin therapy, weight gain is a common side effect faced, especially in patients who had been catabolic before.
That must be discouraging for the patients.
Yes, it can, especially because many type 2 diabetics are already trying hard to manage their weight. That's one reason why careful dose adjustments, diet counseling, and sometimes adding weight-neutral drugs like Metformin or GLP-1 agonists can be helpful.
Okay, so watch for hypoglycemia, rotate injection sites to prevent lipodystrophy, and be mindful of weight changes. Alright, Serena, before we wrap up today's episode, let's do a quick recap starting from the very beginning. We've covered so much, I lost count.
Definitely. Let's start with the oral antidiabetic medications first. First up, we discussed the insulin secretagogues, liberide and glimepiride. They work by stimulating insulin secretion from beta cells by closing potassium channels. But they come with risks, particularly hypoglycemia and weight gain. We mostly use them in early type 2 diabetes, but avoid them in pregnancy and kidney or liver dysfunction.
Next were the meglitinides, like repaglinide and nateglinide, which are also secretagogues, except they're faster acting and shorter lasting. They're great for controlling post-meal glucose spikes, but still carry a risk of hypoglycemia if meals are missed.
Then we moved to biguanides, mainly Metformin, the superstar first-line therapy. It works by decreasing hepatic glucose production and improving insulin sensitivity without causing hypoglycemia. The main issues are GI side effects, rare risks of lactic acidosis, and it's contraindicated in renal impairment.
After that came the thiazolidinediones, TZDs, pioglitazone and rosiglitazone. These are insulin sensitizers working through the PPAR-γ activation. They improve glucose uptake, but carry risks like fluid retention, heart failure, weight gain, and fractures, so careful patient selection is key.
We followed that up with modifiers of glucose absorption, which were the alpha-glucosidase inhibitors like Acarbose and Miglitol. They slow the carbohydrate digestion, leading to lowering the post-meal glucose rise. But they cause a lot of GI side effects, mainly bloating, diarrhea, and flatulence. Would you like to go over the famous gliptins, Jude?
I would love to. We have the DPP-4 inhibitors, the gliptins, like sitagliptin. They enhance endogenous incretin hormones and help the body secrete insulin more naturally, with minimal risk of hypoglycemia. But rare side effects include pancreatitis.
And we also talked about liraglutide and semaglutide, which are GLP-1 receptor agonists. They increase insulin secretion, decrease glucagon, slow gastric emptying, and help with weight loss, but can cause nausea and very rarely pancreatitis. Some forms are oral, others are injectables.
And the last one for the oral antidiabetics are the SGLT2 inhibitors, like canagliflozin. They block glucose reabsorption in the kidneys, leading to sugar going away in the urine. Major benefits include weight loss, blood pressure reduction, and cardiorenal protection. But there are risks like UTIs, genital infections, and rarely ketoacidosis.
Then we shifted our gears into the injectable ones.
Firstly, we talked about the cases where we need insulin. That would be in type 1 diabetes, in cases of severe hyperglycemia, after oral therapy failure, during illness, surgery, and pregnancy.
That's impressive, Jude. Then we broke down the types of insulin based on how long they take to work. 1. Rapid-acting insulins like Lispro and Aspart for mealtime bolus coverage. 2nd, short-acting regular insulin, slower onset, needs time before meals. 3rd, intermediate-acting MPH used for basal insulin but has a peak. Lastly, long-acting insulin like Glargine and Detemir, providing steady background levels.
And let's not forget basal bolus therapy, combining long-acting basal with rapid-acting bolus to mimic the pancreas's normal function.
From there, we got into the impressive insulin pumps, which provide continuous subcutaneous insulin infusion with programmable basal and bolus doses for better flexibility and control.
We also reviewed insulin's adverse effects. Firstly, hypoglycemia, with signs such as fast heart rate, sweating, tremors, anxiety, and confusion. Secondly, lipodystrophy, which is fat changes at injection sites. And lastly, weight gain due to insulin's anabolic effects.
And finally, we mentioned non-insulin injectables, like pramlintide, an amylin analog which affects gastric emptying by slowing it and blunts post-meal spikes, used alongside insulin.
Wow, that was a lot, but a complete tour of the world of antidiabetic drugs. I'd be surprised if we missed out anything.
Exactly. And the big takeaway from our discussion today is that treatment needs to be tailored. Different patients mean different strategies. Sometimes we use oral agents, sometimes insulin, and it could even be a thoughtful combination of both.
And when patients are educated and monitored closely, we can minimize these side effects and maximize the benefits of insulin. Before we officially close out today's episode, I think we should do a few practice questions to lock everything in. Ready?
Ready, let's go.
First question. Which oral antidiabetic drug class works by decreasing hepatic glucose output and improving insulin sensitivity without causing hypoglycemia?
That would be our superstar, biguanide, Metformin.
Awesome. Next one. A drug that causes weight gain, fluid retention, and works by activating PPAR-γ to improve insulin sensitivity. Can you name it?
Those would be the TZDs like pioglitazone and rosiglitazone.
Great. Now a true or false for a little change. Sulfonylureas can cause hypoglycemia even if a patient skips a meal.
True. Sulfonylureas stimulate insulin secretion independently of food intake, so skipping meals while on them is risky.
Okay, a little challenge for you, Serina. Which injectable therapy mimics natural GLP-1 activity, promotes weight loss, and slows gastric emptying?
I got this one. That would be the GLP-1 receptor agonists, like liraglutide or semaglutide. How about you try the next one, Jude? Let me ask you about insulin. What's the major difference between MPH insulin and glargine insulin?
MPH is an intermediate acting insulin. It peaks and can cause hypoglycemia if meals are not timed well. On the other hand, glargine is a long-acting basal insulin. It provides steady coverage with no pronounced peak.
Perfect!
All right, last one. I might get you with this one. Name 2 important adverse effects of insulin therapy that patients should be counseled about.
That's easy. First, hypoglycemia, where the patient could experience fast heart rate, sweating, and confusion. Second, lipodystrophy, either loss or accumulation of fat at injection sites, if sites aren't rotated properly.
Perfect score, Serina. I think we're ready to wrap up and stretch our backs.
Yup, that was a great review. Thanks for quizzing me, Jude.
All right, everyone. That brings us to the end of today's deep dive into anti-diabetic medications. We took a look at both oral and injectable.
Thanks for sticking with us. We truly covered a lot, from the earliest oral drugs to the newest injectable therapies, even combinations, and hopefully made it a little easier to remember.
Whether you're reviewing for exams, prepping for clinical rounds, or just love building your medical knowledge, we hope this episode helped you piece it all together. And remember, managing diabetes is all about using the right combination of tools that suit each patient's needs.
If you enjoyed this episode, make sure to check out our other topics where we keep breaking complex medicine into bite-sized, memory-friendly pieces. And until next time, keep learning, keep asking questions, and stay curious.
This is Jude and Serina signing off from PodBites. See you in the next episode. Bye-bye!